Thank you very much. So my task is to speak about pre-transplant treatment, as was already alluded by the previous speaker, and I think it is indeed important. So we know since long, of course, when you look at this slide, that if you look at all treatments, the more you are out of the beginning of the treatment, the more important is the role of resection, and especially of total resection, which is a transplantation. And already a decade ago, there was an indication that the results after transplantation have been improved a lot. And the reason why this is of course, that we introduced in our selection criteria, especially in the Western world, the Milan criteria. And you see, this is the original publication in the New England Journal of Medicine, only related to 49 patients. And it's always good to see if the same center has validated the results in their own experience, and this was the case, as you see, that the results remain exactly the same in a cohort which was augmented to 250 patients. We know, of course, that Milan criteria is a starting base, but that this criteria exclude in an unjustified way a lot of patients, and the exclusion rate in some centers have been published going up to 37%, so it means almost 1 out of 2 patients. And if we go and look in the evolution of these extended criteria, and I think the first speaker was a good introduction to what I will show you, is that we have, I think, to go away more and more only from the imaging, taking in account the diameter and the number of nodules, but that we have to add the biological behavior of the tumor. And you see that this has been shown in several Asiatic centers, that you have to combine, if you want to extend in a justified way to your indications, you have to combine morphology and biology. And we can do this, of course, when we want to go further by looking retrospectively at results in patients who were Milan out, and this was done, for instance, by Mazzaferro, when he created this up to 7, I would say, idea. But I think it's not enough. We can do better, because up to 7 is still sticking to numbers and diameters, and I think this is completely gone and over. So how can we expand safely the criteria? We can look at different, I would say, biological behaviors of the tumor. We can look not only at static values of tumor markers, but we should look at the dynamics of tumor markers. We can look, and we did this, and we heard yesterday also from Dr. Suk and from the Sujima group, we can look at neutrophil lymphocyte ratio, but also look at platelet lymphocyte ratio, which gives also information. We can look at radiological progression. It's also an expression of tumor behavior. But I think we should go to the concept that we use in every treatment of cancer. If it is colon, breast, we should do the same thing for the liver. We should look, in fact, at neoadjuvant and adjuvant therapy. And I think we are now able to combine immunosuppression with an oncologic treatment without danger. I think there is enough evidence for this. So the best neoadjuvant treatment is, of course, local regional treatment. And I think if we go to apply sound oncological principles, and I really do not understand why this has been forgotten for so many years, we should look at the neoadjuvant treatment and probably later on also adjuvant treatment, but we must especially look at the response, the biological response of a tumor given to a chemotherapy or radiotherapy, and we can maybe combine both of them. And there are criteria to do this. We published this recently, the Brussels group. We should qualify, if we speak about local regional treatment, we should look like in other fields of oncology to objective response criteria. The mRECIST criteria exist, the tumor markers exist, we can use them. So if we want to go further, we can select better now, not only on Milan criteria based, but also on response to neoadjuvant therapy. And the best neoadjuvant therapy is, of course, in a cirrhotic patient, a local regional treatment, because systemic chemotherapy does not work till now. So we have, in fact, as shown, we did not know from each other that we would say exactly the same, but Dr. Suk showed exactly what is right. We should come away from statics, and we should go and look to dynamics of tumors. Now, if we look at local regional therapy, the best local regional therapy is in principle a surgical resection, but because then at least you know what you have done, and the pathologist can examine the specimen. But we know also that resection is a limited application. It is another intervention for a sick patient. There is surely a more difficult transplantation procedure in many cases, not in all cases, and Daniel Cherki showed that it is maybe better if we want to do this to go to laparoscopy because it will have less influence on the transplant surgery. But I think what is forgotten in the resection surgery, and if you read the papers which advocate this, there is in fact in all these papers up to 40 and maybe 50% of patients which lose the chance to have a curative transplantation. They lose their transplantability, and it's usually the best candidate because the patient who has a resection is usually a Milan-in patient. If we go to the non-surgical side, we have different possibilities to do, and this is now difficult if we speak about the optimal pre-transplant treatment, because there is a lot of confusion in our minds, in the minds of our medical colleagues, and also in the way how to follow up these patients. We can of course use alcoholization, a percutaneous ethanol injection, or radiofrequency. Usually it is shown that in the few randomized controlled trials, radiofrequency is a good method. It's better as alcoholization, but we should not forget that alcoholization, if it is done in a perfect way, it is a very cheap and also very good treatment of these patients. The best treatment is probably, as said before, also the TACE, and these are a good example. This is a patient which is out of the Milan criteria, and you see that repetitive TACE can give a good response, not only from the morphological side, as you see here, the tumor has been reduced by 50%, but especially from the biological side, you see that the high level of alpha-fetoprotein is now normal, and this patient was transplanted 7 years ago and is without any recurrence, and we have all patients like this. Is this applicable to patients who have more than one tumor? It is. As you can see, this is a patient with several tumors. He got several TACE. You see, even with a complicated TACE, but we didn't have to operate this patient. Another TACE, and finally he has been transplanted. This patient is also alive more than 10 years after transplantation. So it shows that we can do much better if we look at biology and if we look at morphology. And we can even do more. It is many times forgotten. You can combine several treatments. This is an example Vincenzo Mazzaferro gave me. You see this patient had a TACE combined with a radiofrequency, but combined with an ischemic induction by blocking the arterial inflow by a balloon catheter. And we know that chemotherapy is much more effective if a tumor is made ischemic. So I think we can do much, much better. It means that we must standardize local regional treatment before the operation. Now, what is the problem of all this? If you go in the literature, I would say the feeling about local regional therapy and TACE is very particular. This is a big French study, has been published recently, and you see, this group say, multi-center study, there is no influence at all if you do TACE or you don't TACE. There is another group, especially interested in this in Innsbruck. They show if you do TACE, there's an influence in survival in Milan-in patients, but if you have Milan-out patients, in contrast to what you should expect, I think, there is no influence anymore. So there is a lot of controversy about local regional treatment before transplantation, I think because we don't look in a good enough way to the results and to the methodology. And it is in contrast, we know all that the evaluation of surgery as a pre-transplant treatment has been very clearly evaluated, because we know all that about 60% of patients recur within 3 years, and we know also which are the limits. But for the evaluation of the local regional therapy, it's completely different. And this is a meta-analysis which has been published in 2006. You can read it in the American Journal of Transplantation, and the authors conclude that there is insufficient evidence that TACE offers any benefit used prior to OLT. But I think the two patients I showed you and the patients Dr. Suk showed you show very well that TACE can be a help to cure a patient with an advanced cancer. And curiously enough, this statement has been confirmed by a recent Cochrane collaboration, but there was immediately a reaction, a letter from 6 well-known interventional radiologists in the United States and in Scandinavia, which are absolutely opposed to this and said that you cannot judge that you cannot make such statements based on what is published in literature. And I think they are completely right. And the reason I say this is because I think that local regional therapy is not equal to local regional therapy. It is not while you treat once a patient that you have an effective treatment. If you take out as a surgeon a tumor, you know that you have done something effectively, but it is different for local regional treatment. And it is the same for alcoholization, radiofrequency, transarterial embolization, which sometimes can give a good result, and chemoembolization. And there are 4 reasons why this is so, in my opinion. The first is that many patients, when they have local regional treatment, there is a technical basis for the failure. This is an example of one of our patients we treated in Brussels. This patient had a huge tumor. He got repetitive TACE. We were very happy. Imaging was showing tumor necrosis, and you see on the explant there is a complete necrosis of the tumor. But this patient had a very small tumor at the other side of the liver, microvascular invasion, and he died 3 years after transplantation of recurrence. So I think hepatocellular cancer should maybe be seen like bladder cancer. It is diffuse cancer in the liver, and I think we should maybe think more when we treat, when we focus on one lesion, that we should not forget the other part of the liver and probably treat it also. That's my personal opinion. The second reason why there is a failure in local regional treatment is that there is a molecular basis to explain this. The Chinese and Hong Kong group showed very well that if you do TACE and you have a necrosis of your tumor, in fact you create an hypoxic tumor zone, but we induce also the proliferation of vascular endothelial growth factor. So it means if you do one TACE, it's equal to no TACE at all. I think we do not know any colon or breast cancer patient who get just one cycle of chemotherapy. So it means that we have to do more systematically, to repeat, to do iterative TACE. The third reason, and this is especially true in the Western world, we don't use all the tumor markers that exist. You see here, these are all levels of transplant patients which has a normal alpha-fetoprotein and which has a very high DCP or PIFCA. And you see it's a good example. This is a patient we treated, and you see after the TACE the alpha-fetoprotein came normal. Many times these patients are not submitted anymore to TACE, but if you look at the DCP level of this patient, the DCP level was abnormal, was pathologic, so it means the tumor is still active and you must treat him. So this is an important message, I think, especially for the Western world, that we should use all available tumor markers. We can have them. And the fourth, I think the most important thing is that now since the sorafenib, treatment of cancer escaped to the surgical community. And many of these patients are treated. It's a good example. This patient get a treatment radiofrequency. And you see it's judged 100% necrosis. We see the patient in the surgical department 1 year later. Look, we have the same tumor at the same place. So it is not a new tumor, it is a recurrence. And we know very well from all local regional treatments that not all patients have 100% necrosis. So it is important to judge, and this has already been shown by Mazzaferro in a paper that I think is forgotten 10 years ago. You treat patient locally. The longer is the time from the treatment to the transplant, the more you will find on pathology viable cells in the tumor. So it means that these patients must go on and have treatment if we're going to progress. So if we make in conclusion the results, we need a standardized approach. We must do it more oncologically. And I will go over this a little bit more rapid. We looked at patients who had several chemotherapies, and there are not many groups who do it. The German group does it. And they showed if you do multiple TACE and you have a response even outside Milan, the result is very good. If you are no response, the result is a disaster. And we put our experience together with 4 centers who work in the same way. And how does it function? We have 800 patients. If we do all local regional treatment, and under local regional treatment they progress their tumor markers above the level of 15 alpha-fetoprotein, you see they recur as well Milan in as Milan out. And if we have patients who do not respond, Milan in or Milan out, if you have a progression of your tumor or your alpha-fetoprotein progress, the patients do very, very bad. And what is important in this study, it was more than 800 patients, it will be published soon. If you have Milan out patient and they don't have these risk factors, I mean alpha-fetoprotein is lowered and the rest does not show a progression, they have the same results as the Milan in patients. So it is important, the difference is 50% in survival, and you see this if you have a progression of the alpha-fetoprotein, the recurrence rate is very high. If you have a resist progression, recurrence is very high also. Then we looked in these 800 patients now, only the patients who got TACE, and we had more than 400 patients. You see, if you have a patient who got TACE, the recurrence rate is much less important, and again the same. If this patient under TACE, the Milan outpatient who has a positive response to TACE, he has the same results as the Milan inpatient, which is a normal patient who has no response also. So it means that we can bring the patients together, and we can even go further and look at the incidence of iterative TACE. And you see patients, especially Milan outpatients, if they have multiple TACE with a response, the results are much, much better than the other patients. So I finish here. I also want to stress that what is forgotten in all these patients is that the TACE is something. This is what I call the neoadjuvant treatment, but there is also another adjuvant treatment in cancer patients, and the best one is to adapt immunosuppression. It has been shown very well in Italy that if you have low immunosuppressive levels after transplantation, in this case cyclosporin, you have less recurrence. And we looked again at these 800 patients I showed you. If you do transplantation without steroids, you have 30% difference in survival with the patients who have been treated loco-regionally. And we know now that tumor patients, in my opinion, they almost do not need immunosuppression. They can be treated all with infratherapeutic monotherapy from the beginning. So in conclusion, we have to extend our knowledge. So if we extend our knowledge based on biology, we can include more patients. And so I think every patient indeed should now be seen as a transplant patient. Response to local regional therapy, and it can be a different methodology, is beneficial, especially for Milan outpatients. But I think we need an urgent standardization of the response evaluation to local regional treatment, and we should indeed move, as been said by Dr. Suk, from statics to dynamics, and we must combine diameter and numbers now with tumor biology. Thank you for your attention.